Okay, thank you for the introduction, which I heard only in Serbian language, so I'm not quite sure what you said, but I think I understood a little bit of it. Uh, to start off with, I would like to express my deepest thank you to Dr. Paul Sharrock and to the organizers for inviting me to give this presentation, and also to invite me to participate this very interesting and exciting um, webinar. Uh, my talk, Individual Medicinal Interventions in Autism-Related Aggressive Behaviors, is based on my clinical experience with intellectually disabled autistic patients, for whom I've been working the past 10 years or so. By education, I'm a biochemist and a neurologist with PhD in toxicology, and then I have also subspecialty in intellectual disability medicine. Um, Before starting to work with this group of patients, I used to work for our National Agency for Medicines, called nowadays FIMEA, and European Medicines Agency, where I was involved with scientific advice given by the health authorities to drug companies. And I must say that period of about 7 years was also very educative in my professional path. Soon after I left the regulatory agency and started working for intellectually disabled patients, I realized how important it is that we in Finland have special centers where both medical and social needs of these vulnerable people are being taken care of. And at that time, thanks to my boss, I took a course in health and social management, a 3-year course at Tampere University, where one of the tasks that we were given was to write a strategy essay. And I wrote it in English simply because at that time I was a board member of European Association of Intellectual Disability Medicine. And at that time there were lots of discussions going on, and I wrote my strategy essay just based on what I had seen, how these services are organized in Finland. So thanks to then my European colleagues and a few Finnish colleagues, we decided to send my strategy essay to be published in a medical journal. And to my big surprise, it was accepted as an editorial with minor changes. And but what this really tells to me is that the kind of service centers that we have in Finland, there is an international consensus for that those kind of centers are really needed. So this is really what I've been working for the past full 10 years, and this is all that I'm going to tell you about. This is based more or less on this our old strategy. Okay, here are the contents of my talk. First, I will tell you a little bit of our history, how the services for intellectually disabled people have been organized in our country, and then go through a little bit terminology before going to clinical realm and going through why do we need individual interventions, and then I will tell you some case examples and describe the challenges that we've had with those, and then at the last part of my talk I will give some suggestions what we think would be good to do in the future. And to keep you awake at this late hour of the day, I have between each section of my talk a photo, and hopefully you also, I can keep you also interested in what I'm trying to say. I just realized that there are, we have all approached this topic from a little bit different direction, and I believe that this talk will again enlighten the big challenge we have in front of us a little bit, again, different perspective. First of all, our institute is nowadays part of Tampere University Hospital, the location of which is shown by a red arrow, and we are providing services to in Pitkäniemi district. Okay, now a little bit about history. Finland has been divided into 16 state-supported regional service districts for individuals with an intellectual disability. In those districts, healthcare has been provided under social care, and interestingly, the work done in these centers has led to several academic dissertations, for instance, for many professors in neurology. And as a matter of fact, I think it was 15 genetic rare diseases has been identified in Finland. Most of them by the late Professor Leena Palotie, professor in genetics, who was very active with her team and with her international collaborators. But the times are changing all the time, and our clinic, for instance, including the institutional rehabilitation care center and the special outpatient clinic, merged with a hospital district in 2009, but we still work under social care. So we are separate from the main hospital, even though we work under the same umbrella. We were among the first ones of those state-supported regional districts who joined the university hospital, and rest of them are doing the same now. But it's a question. It is a big question mark what our role will be in the future, and there are vivid discussions going on because of our social and healthcare reform. Okay, then a few words about terminology. First, I would like to emphasize that intellectual disability is not same as dementia. Even though both the symptoms and causes of these two entities do overlap. But intellectual disability means limitations in cognitive functioning and skills, including communication, social and self-care skills that have developed before reaching adulthood for any reason. Whereas cognitive decline developing in adulthood is called dementia. And also it should be realized that even people with intellectual disability may develop dementia in their adulthood. It is a bit confusing, but these intellectual disability and dementia should be considered as different entities. And then, well, autism spectrum disorder maybe is of course very, you are very familiar with that one, but let me state it here again. It's a developmental disorder of variable severity that is characterized by difficulties in social interaction and communication and by restricted or repetitive patterns of thought and behavior. Okay, what is the relationship between intellectual disability and autism spectrum disorder? Well, a significant percentage of children diagnosed with autism spectrum disorder meet criteria for intellectual disability. But in some severely affected autistic patients, the determination of intellectual disability may be impossible. Anyhow, we know that from both an organizational and clinical perspective, the autistic spectrum disorders belong to the most challenging comorbidities in intellectual disabilities. Well, now we move to our clinical realm. And I want to highlight here that I'm mainly talking about those autistic intellectually disabled patients who have been unresponsive to all kinds of treatments that they have been provided. So what do we see in our closed clinical wards with those patients? They have destructive behaviors, which include self-injurious behavior, like banging the head on the wall, biting, tearing off the hair, nails, and skin. And I must say that as a neurologist, it's a big mystery to me how these autistic patients who are banging their head on the wall, how do they not develop any contusion, any subdural bleeding or intracranial bleeding. When I started working with these patients, I used to send these fellows to have their CT scan or brain MRI scan, and they always came back negative. So I've kind of stopped doing that, but I don't know how is it possible that they do not hurt themselves more than they do. Anyway, then they may be also aggressive toward other people and or property. They can be hitting, strangling, biting, kicking, tearing, breaking, and throwing objects. All this means that both patients themselves and their caregivers are at risk of serious physical harm. And they are not only at risk, but serious physical harm also happens. Okay, what are we trying to do to these patients to minimize their undesired behavior? We try to base our clinical practice on underlying causes of problem behavior. And we have a multidisciplinary team providing various behavioral therapies, psychosocial interventions, speech, sexual, music, and so on therapies. And then we have pharmacotherapies, which pretty often is unfortunately off-label, to be precise. So treatments based on neurobiological mechanisms would be welcome. How do we determine the underlying causes of challenging behavior? First, we need to see if the question is of psychosocial or medical problem. This differentiation can be usually done by good anamnesis, interviewing the parents or the caregivers, and whenever possible, the patient, him or herself. and then by examining the patient as carefully as possible. And if the question is of a medical problem, then we need to see whether there is some somatic cause, for instance, abdominal pain or toothache or anything that should be treated and that is bothering the patient, so that the symptom for this somatic symptom is actually bad behavior. Then we need to consider if there is some unrecognized neuropsychiatric comorbidity, including epilepsy, dementia, psychosis, bipolar disorder, and so on. Even epilepsy can occasionally present as some kind of behavioral symptom. And then this undesired behavior can be related also to intellectual disability syndrome or autism itself. And very importantly, sometimes the challenging behavior can be an adverse reaction to the medicines the patient is on. But in spite of our efforts to try to find the right course for the bad behavior, the underlying cause behind it may be vague, resulting often in more or less experimental medication and then further problems. The problem is that we have high expectations of medicines, even though the evidence on the benefits is very limited. And but this is understandable because we want to do something to stop destructive behaviors that were unresponsive to multidisciplinary interventions. Because of severity of behavioral symptoms, because of diagnostic challenges, and because there are no other efficient evidence-based treatments. And all this results in off-label use of medicines, polypharmacy, and then adverse reactions. Well, what are the established medicines for autism-related behavioral symptoms? In Europe, risperidone is an only medicine that has an official indication, but only for 6 weeks use in aggressive or other disruptive behaviors related to intellectual disabilities. There are 2 pretty small placebo-controlled trials, 1 open trial, and a few case reports to support this indication. Aripiprazole has an official indication in the US for irritability associated with autistic disorder in children and adolescents aged 6 to 17 years. There are 4 randomized controlled trials to support this indication, but just like with risperidone, its benefits in long-term use are somewhat questionable. Okay, but here, this slide gives a list of all those pharmacotherapeutic groups that are used for these patients to manage their behavioral symptoms. Here, I would like to remind that even though many of these medicines there may be some response to these medicines, but in the long run, we may end up having problems. For instance, with For instance, with ADHD medicines, we know that in the long run, they can actually aggravate aggressive behaviors. Then we know from antipsychotics that they can worsen epileptic seizures, and many of these patients do have epilepsy as a comorbidity. Then we know that clozapine, which can be very effective toward aggressive behavior, aggressive and self-destructive behavior, can actually cause epileptic seizures. But when clozapine turns out to be efficient, we accept it causing epileptic seizures, and we just add anti-epileptic to the patient's medication, usually valproate. Then about epilepsy medicines, we know that especially the newer generation anti-epileptics can cause behavioral problems. So whatever we do, we need to follow the patients very carefully and to do one change at the time to try to figure out what is caused by what. Oh. Okay, now we get to, I don't know why these slides keep running like this. Anyway, now we are going to third part of my talk, where I'm going to discuss why do we need individual interventions. And in the photo, you see our institute in summertime. Those three buildings in the front belong to our institute. Okay, the justifications for individual interventions are pretty self-evident. The thing is that non-pharmacological and pharmacological treatments are insufficient for the most severely affected patients. And there is no one-fits-all treatment for patients with numerous different comorbidities and heterogenic etiologies of their intellectual disability and autism spectrum disorder. Intellectual disabilities are roughly classified to genetic, acquired, and multifactorial. And autism spectrum disorder belongs to multifactorial group. And it has become more and more evident during the last years that autism spectrum disorder stems most likely from immune dysfunction. And at least no one is anymore claiming that autism is related to a problematic relationship between a mother and a child. So we have a very heterogenic group of patients, but their symptoms can still be very similar. And because of their heterogenic etiologies and comorbidities, they need all different treatments. And then one more justification is that treatment-resistant behavioral symptoms cause inhuman burden to the patients, their families, and their caretakers. This is very clear. But also, they cause high cost to the society. For instance, at our institute, the cost to the society per patient is about 1,000 euros per day. And that does not include possible physical harm caused by that patient. And if we consider that the most of these patients are young men with long life expectancy in front of them, we are talking about astronomical sums of money. But then again, if we turn it around, we can calculate that whenever we find efficient treatment just for one patient, it means significant savings to the society. And there is one more very, very important justification for individually tailored treatments. and that is adverse reactions caused by polypharmacy, which do occur but are often very, very difficult to recognize. And next I have our my first case, very illustrated case example. Here, the question was of a young man who was diagnosed with intellectual disability and autism spectrum disorder. At the age of 8, his tantrums and aggressive behavior were so bad that risperidone was initiated. To start off with pretty good response. But gradually, its dose had to be increased, and while the dose was increased, he started having first every now and then infrequently tics and movement symptoms, which by time became more and more frequent, and as also his symptoms worsened. So new drugs like valproate, quetiapine, protexine, etc. were added to his medication. Well, all these medications, he was not at the same time on these medications, but these were tried at some point of his treatment with more or less good or bad outcome. Well, over the time, the movement symptoms became more and more frequent, and including the compulsive involuntary choreoateoid type movements affecting the trunk, limbs, facial area, and mouth, twitching, dyskinetic extensions in the back and in the neck, and the neck became continuous and eased only at sleep. It's a pity I was not able to show. I'm not able to show you a video, but to describe what the patient looked like, I would say that he was moving like a worm on a table, and from table to the worm, and it was really very, very bad situation. And all this caused to him sleeping and eating problems, and significant weight loss. He lost 12 kilos in 8 months. He was very anxious and in constant pain. Also, self-mutilation with several lacerations and infected wounds resulted in sepsis and intensive care. It took years before before it was understood what was the right diagnosis, and that was tardive dyskinesia. The patient was already 7 years, 7 months old at that time. Before that, brain MRI and other diagnostic tests were found to be negative. The patient was tested, for instance, for rare diseases such as Huntington's and Wilson's disease. And his symptoms, his worst continuous movement symptoms, they continued about 5 months before it was decided to stop all antipsychotics. But movement symptoms continued, and this is actually as expected, because tardive dyskinesia caused by anti-epileptics can and often is irreversible. Well, then conservative treatments for tardive dyskinesia were tried, including medical cannabis, tetrabenazine, levetiracetam, but they all failed. So finally, a neurosurgeon was consulted, and it was decided to try deep brain stimulation that is used to manage dyskinetic symptoms in Parkinson patients. And luckily, deep brain stimulation helped our patient to get almost back to normal so that he could walk and eat and sleep again normally. For further details, you may read our our case report that has been lately published in Journal of Child and Adolescent Psychopharmacology. Okay, so what would be the possible experimental individual treatments? As mentioned, patients with heterogeneous etiologies but similar symptoms benefit from different individually tailored treatments based on literature and our own limited experience. We have various dietary interventions, electroconvulsive therapy, and other non-invasive neuromodulative treatments like transcranial magnetic stimulation. Then we have cannabidiol, some data on cannabidiols, on immunomodulative treatments like IV immunoglobulin. But any IV medications would be difficult to apply because these patients actually should be put to sleep in order to be able to medicate them intravenously. Okay, now we get to the fourth part of my talk. I have now a few successful cases to tell you about. The first one relates to a young man with intellectual disability, autism and epilepsy. And he had been in a closed ward since he was 15 because of very aggressive and self-destructive behaviors. And many kinds of medications and combinations of medicines had been tried. And when our professor in intellectual disability medicine, Maria Arvio, met him, she remembered, well, Nina has been talking something about gluten casein-free diet. And I've been talking about it simply because it seems that there is the most of the data we have in the literature comes from gluten casein-free diet. And so it was decided that this patient should be put on gluten casein-free diet. At that time, he was on valproate and on olanzapine medication. He was overweight and he had severe facial acne. And the transition to a gluten-free and casein-free diet proved to be a true turning point for this patient within just 4 months. His somatic condition clearly improved, and his acne disappeared, and his devastating behavioral symptoms also disappeared, and they have not returned in over 2 years of follow-up. When I met him, he's a tall guy, almost 2 meters tall, and he weighs almost 100 kilos. So when I met him, he was being taken care of by a nurse who was about half of his size, and there was no sign of any aggressive behavior. So that was some kind of miracle case to me, and really opened our eyes that yes, diet does matter. Okay, I don't know why these slides keep going like this. Sorry about this. But anyway, another good example, here are two more patient cases. Very similar one with a previous one, but except that these two did not respond to the diet that we had tried to them. Both of these were young men diagnosed with intellectual disability, autism spectrum disorder, and epilepsy. And before we decided to try electroconvulsive therapy, we knew that every time they got some spontaneously epileptic seizure, their behavioral symptoms stopped for a week or so. And the same thing happened when a seizure was caused by psychiatric ECT. Unfortunately, we were unable, well, we continued this treatment for about 6 months for both of them, but unfortunately we were unable to continue them for several bureaucratic and other reasons. But we did write a case report of this and thought that probably in these two patients the question was of forced normalization that has been described in the literature, and which means that epilepsy and aggressive behavior or psychosis are two extremes of the same phenomena. And then, of course, the use of ECT raised ethical questions simply because our patients cannot give their informed consent to this treatment. But of course, they cannot give their informed consent literally to anything. And all the pharmacotherapy that we use, it's all off-label, and they cannot give their informed consent even to those. Okay, what are the challenges? The first one is pretty evident, but I'm not going to address it more than just to state it here because it would be too broad it would be out of the scope of this talk. Well, autism spectrum disorder is a lifelong, multifactorial, and fastest growing neurodevelopmental disability. So the question is how to stop this trend. No answers to that, but instead we have some suggestions to the following two challenges. The first one of which being is that specific diagnostics of behavioral symptoms is not always possible. For instance, we do not always know whether the aggressive or self-destructive behavior is because of autism or because of catatonia or because of psychosis. In the literature, this is called an iron triangle, and the only way we can know, we can at least guess what is to try different medications, because catatonia is not treated by benzodiazepines, and then psychosis should respond to antipsychotics. And then also the diagnostics is challenging because of neuropsychiatric comorbidities like epilepsy, which are common. So the next challenge is how to find the right treatments for the right patients. Do we need to keep on experiencing and failing and trying again and again until we finally succeed to find something? And what about the scientific evidence when we find something? How do we know that whatever we did is not just a coincidence? Well, here are the open questions that we need to address. And those are, what are the best biomarkers to help in achieving more accurate diagnosis? Out of numerous, often costly laboratory tests there are available. And what are the best biomarkers to help in finding the most optimal treatment? Out of numerous, again, available experimental treatments, case by case. and then also we need to know how do we measure aggressive behaviors. We know that it can that the days are a bit different. Behavior may fluctuate from day to day, from one season to another one, and then so it's not a simple thing to measure. And then how to find the much needed evidence-based proof for a spectrum of disorders with multifactorial causes but similar behavior symptoms. And also importantly, how to enforce collaborative efforts. Those are needed to address the above questions, and that is one of the reasons I'm very excited talking here right now to all of you. Okay, now we get to the fifth part of my talk, where I discuss some possible thoughts what could be done in the future. Oops. Okay, regarding diagnostics and biomarkers, all the tests that we decide to do have to be based on case-by-case consideration. So clinical knowledge and expertise are very, very important. And all this means that we need to collect a good medical history from the old medical records, and by interviewing the parents and caregivers and patients themselves whenever possible, get a status and a follow-up, and then we need to decide what laboratory tests we want to do. Sometimes we need neuroimaging or EEG recording, and every now and then we want to do further genetic testing. But what about how to measure aggressive behaviors in autistic patients in a reliable way? After discussing with many colleagues and experts, we thought that this Cohen-Mansfield Agitation Inventory, CMI, might be useful. It has originally meant for the assessment of agitated behaviors in elderly persons, and it is a caregiver's rating questionnaire which consists of 29 questions on agitated behaviors, each of those rated on a 1 to 7 point scale of frequency, with ratings pertaining to the 2 weeks. In other words, the lower the score, the combined scores from this questionnaire, the better the patient is doing, and the higher the scores, the worse the patient is doing. And okay. And in this table, you see the symptoms that this questionnaire is evaluating. There is hitting, kicking, grabbing, pushing, throwing things, biting, scratching, and so on. And we wanted to know how reliable this questionnaire is. Does it depend on who fills the questionnaire? So we have compared CMA data collected by 3 different nurses from 26 autistic patients with ID, and without going to further details, it seemed that this is pretty good and pretty reliable method to measure the frequency of aggressive behavior. Okay, what about the evidence-based proof? How do we get that? It is very clear that randomized control trials would be unethical, and most likely also unreliable due to heterogeneity of this patient group. Instead, we could consider single case experimental designs in which each subject acts as his own control and an agreed endpoint is measured repeatedly before and after the experimental treatment to get statistical power. These designs are already being used quite widely, for instance, in applied and clinical behavior analysis, and they are becoming more and more common also in health sciences and medicine. In the most simple case, this kind of single case experimental design means AB kind of system in which the same intervention results in same outcome in one patient time after and after again. So then it can be calculated statistically that the question cannot be of a coincidence but of a real effect. And I guess this could apply, for instance, for our electroconvulsive therapy. Okay, I'm almost at the end of my talk. Before going to take home message, here's a photo of my home city, how it looks right now. It's pretty dark, but we have Christmas lights and no snow here, like I heard that you have in southern parts of Europe. Okay, but to the conclusions. For autism spectrum related aggressive behaviors, we need multi-professional teamwork, behavioral analysis and psychosocial interventions, better diagnostics and exclusion of somatic disorders, appropriate medication based on accurate diagnosis, avoidance and recognition of adverse reactions, and very importantly also collaborative efforts to plan individually tailored, efficient experimental treatments, design single case experimental time series, and to find new treatments based on neurobiological mechanisms. Okay, and here I want to once more I think that when listening all these lectures yesterday and today, I have understood even better than before what some people have meant when they have said that it's very important to be consistent in your doings and in your not doings. And I think that you who have been working on this field for decades have done really a great job. And I thank you very much for that. And I feel that every day we learn from these autistic patients and also from each other a lot. So I want to cite here Sir Winston Churchill. I'm sure many of you know him. Who has said, at least according to Mr. Google, continuous effort, not strength or intelligence, is the key to unlocking our potential. Okay, and my last reference shows our scientific papers, and the most important one to which I have referred in my talk here. And now it's time to look to the future. Within 1 or 2 months, it should look like that, like this here. But now it's very dark. But anyway, thank you very much for your attention.
Thank you, Dr. Nina. This was really a very interesting presentation, I must say. And as you said, it's a multi-professional teamwork that we need. And unfortunately, we don't always have that, but it's definitely this personalized approach to treating every patient, because in medicine, 1 + 1, it's not always 2. So I need to ask you one question. It's not regarding the aggressive behavior, but it's regarding epilepsy. In fact, it's regarding pharmacoresistant epilepsy that I see quite a lot these days. And do you have any suggestion on how to treat pharmacoresistant epilepsy? Are there any interventionist approaches that you had experience of being successful?
Well, you may try ketogenic diet is one possibility, but the problem really is that what many epileptologists have been saying, that it's that there is about 30% of those patients who do not respond to any of the available anti-epileptics.
Right. So it's a big number.
It's a big number, but interestingly, a couple of years ago we had a seminar on status epilepticus, and it turned out that these intellectually disabled patients, they have very seldom status epilepticus for some reason, even though they do have more or less frequently, they do have epileptic seizures, but they usually do not develop to status epilepticus.
Right.
And we don't know the reason for that.
Right. And just one more question, because you were mentioning gluten and casein-free diet. In your experience, does that help with epilepsy? You mentioned one case, though, but just with the other patients.
No, I don't think ketogenic diet might. Yes, but I don't know that gluten-free, casein-free would help, would improve epilepsy control. No,
okay.
Not that I know of.
Because I remember Professor Reichelt in one of his papers, he was talking about 1,4-casomorphin 1,4-amide, which could appear in urines of children with epilepsy, but there was no, I mean, you know, obviously there was no results of saying if we exclude it, they're not going to have epilepsy, but it was just a trend they were seeing. I mean, it was just a research. I guess we need to see more of this research to maybe look more into detail about this. But okay, thank you so much. And also it'd be really good to have your references. If we could have your references and maybe use them, maybe some professionals will want to look maybe more into the detail of that. So that would be great.
Yes. Okay, very good.
Thank you so much. Thank you.
Thank you.